on to the second talk in the list, which is Dr. Swaminathan, who will present on behalf of Dr. GHOSH on novel AAV vector designs, retinal dystrophy.
Thank you. It's coming up. Yeah. Good morning, everyone. And sorry, I'm here on behalf of Arkasubhra. He's the brainchild behind our gene therapy program. He sends his apologies. He's very unwell, or else he would have been here. And I'm part of his team, but I'm trying to fill his very big shoes. So pardon me if I just falter. Just to start, we are from a city called Bangalore in the state of Karnataka. Apart from good science, the state also has some beautiful coastlines and mountain ranges if you wish to visit when you're free. So this is going to be the brief outline of how this talk is going to be split. So the introduction is going to be on gene therapy. The main aim of gene therapy is to provide patients with a healthy version of the gene using the currently available 4 different strategies. You can replace by gene replacement or augmentation using the functional copy of the gene, or you can perform gene editing of the mutated gene, or gene silencing using degrading the miRNA and modify the gene therapy sequence by altering the expressions, and some of them are already in clinical trials. This is just the different strategies. The reason why I'm telling you this strategy is in vivo gene therapy, it's mostly vector-based, and viral vectors play a very important role in delivering the functional copy of the gene. And adeno-associated virus today is going to be our focus of discussion. From a very humble beginning as a contaminant, it just evolved itself to be one of the preferred viral vectors in gene therapy, the adeno-associated virus. And there's already approved drugs based on adeno-associated virus for gene therapy applications. Quite a few over there, which you can see. The reason why it became so popular is because of its efficient delivery of genes in both dividing and non-dividing cells, and its high level of the transgene expression, and particularly very low immunogenic, and the most important is non-integrating, unlike the lentiviral system. So these are the salient features as to how AAV became one of the choices in gene therapy applications. And the advantage here, what we have is its serotype and tropism. Okay, we have multiple serotypes, and each of these serotypes have specificity towards certain targets and tissues. And we have quite a range for its tropism towards the eye and various tissues in the eye. But the most important part is how do we optimize these vector designs in order to improve this efficiency? One may ask, why is there a need for such a optimization process? One of the hurdles with AAV vectors is its packaging capacity. It's approximately 4.7 kb, and some of the genes may be beyond that. So that is one of the major packaging capacity. And the second one is if you increase their transduction efficiency, you can reduce the amount of the viral vectors you're going to inject. That will bring down however low immunogenic it is, it still may have some immunogenic response. So reducing the dose is always going to be helpful. And if you reduce the dose, you also bring down the cost. So these are the 2 hurdles which we are trying to address using vector designing system. And the 2 examples which Arko wished to show you today is using a dual hybrid vector system for transgene engineering to address the packaging capacity, and also to improve the transduction efficiency using the capsid engineering process using insertion peptides. 2 examples. And his lab, our lab, but he primarily drives it, has mastered the technique of improving the transgene processes as well as the capsid processes, variety of them. And we have the entire vector production facility in process as well. So the first example is the transgene engineering, that is a dual AAV vector. How do we improve its AAV vector as used for a bigger gene? So many of these genes as listed here may not be suitable because of the AAV's low packaging capacity. To address that, the strategy which has been followed around the world and including in our lab is that using the truncated or the split gene process, where we split a gene into 2 parts and then let it recombine inside the target cell. There are various strategies. It's called the dual vector strategies. You have overlapping vector, transsplicing vector, hybrid vectors and NTN containing vectors as well. Today I'm going to show you an example of what we do with hybrid vectors, for which ARCO has the patent for. This is a very simplified version of what the dual vector strategy is: to take a piece of genes, split them into two, package them into two different AAV virions, and inject it into your target cell or tissue, and they get combined, reconstituted inside the cell. So how does it actually work? So a single gene is split into two parts, and it gets packaged in two different virions. The first way, it utilizes the recombinogenic capacity at the DNA level to combine these two genes. One is via the homologous recombination, and where you have a spliced donor site and a spliced acceptor sites, and there is an overlapping region. And once they come into the cells, the central part gets spliced out, and you have a mature RNA for your target gene. The other way is where the recombination happens at the ITR level. Okay, so these are the two main strategies in which you have a complete formation of your intended RNA, which then translates into proteins. But in this as well, how the transgene engineering was optimized was putting these two overlapping sequences, or optimized overlapping sequences. This one is highly recombinogenic. This one, in addition to being highly recombinogenic, the also has splice and enhancing introns, so that it removes these regions during the ITR combination. And some of the examples we wanted to show is using the Stargardt's disease, and we are very familiar with what happens with Stargardt's disease, along with lipofuscin accumulation, drusen formation. You lose your central vision, and also in the Indian cohort, we do have a lot of ABCA4 mutations in the patients. So we are going to use that as an example to show how the dual vector strategy can be very useful. So what you see here is the retinal fundus autofluorescence image of a normal person, and you have the Stargardt's patient, and you can see enhanced autofluorescence. And in the ABCA4 knockout animals, you can see the increased autofluorescence as well compared to the wild type. So using this animal model, and we are using blue light to induce the retinal degeneration, because normally it doesn't degenerate by itself. So the BL stands for blue light induced degeneration. When you use these two, this is your control AAV treatment, where you only have one half of the gene, because you are using the dual hybrid vector. So in these two, one is the splice enhanced introns and the overlapping alkaline phosphatase sequence. You can see a very good reduction in the autofluorescence compared to your wild type as well as your control group. This clearly shows the dual vector strategy actually applies and works very well in the system. So I'm not showing you some of the in vitro results, but we're jumping and showing the whole thing in the in vivo setup. And not only does it reduce the autofluorescence, it also regains or maintains the retinal architecture as well. So the animal develops this retinal degeneration following blue light in 4 to 6 months. So all the injections happened during that time period. And it was left for 3 months for us to see the endpoint results. Both structural and after the structural things, we wanted to see the functional aspect of the process. And what you see here is the ERG, the electroretinogram. You can see the controls, that is the ABCA4 knockout ERG plots. And what you can see is that in both the cases of both SEI, that is the splice enhancer introns dual vectors, as well as the overlapping alkaline phosphatase dual vectors, you can see the return of a normal ERG activity in these animals. And this is this shows you the quantification of the ERG. This helps you understand and appreciate that the SEI, which is both SEI and the OAP system, are highly recombinogenic. One is far more superior because of the splice enhancement introns. You can see the improvement is much better than the other one. And in addition to that, what was observed was after the vector transfection in these animals, you can see increased ABCA4 gene. Along with it, you can see increase in level of opsins as well. Okay, and the SEI group showed a bit slightly higher opsin levels compared to the OAP groups. So that is the first example of the transgene engineering. And the next one we would want to give an example of capsid engineering is to improve the transduction efficiency. Here what we have done is we used a rational design approach, and we have taken, so that's 8 minutes? Oh, I see. Okay, so should I?
Time is.
I'll take 1 minute.
Yeah.
It's almost done. So we have an insertion peptide into the capsid, and we have two of them. Don't worry about the C and T. This is our internal naming. Insertional peptides were included into the capsid. The capsid integrity was good, and all the quality controls was checked. And what you can see here in AAV2 in the animals after 6 weeks, you can see an increase in the GFP expression when you have the insertional peptides compared to the wild type AAV2. A similar example is for AAV9. When we inserted a peptide in the capsid, it enhanced the ability to transduce, and you can see the expression has gone up. And with that, the summary is we do have a good dual vector system as well as capsid and capsid engineering system to improve transduction efficiency. And the next couple of slides is just pictures to show where we are based. That's the hospital, and that's the center which ARCO leads. And that is the class 100 facility, which has been recently approved for clinical grade vector production. And he has the entire process in place. And these are the clinical trials, which one of them is approved and the other ones are in preparation. Along with it, other preclinical studies are ongoing, just not for the eye disease, but it's beyond as well. Both sickle cell as well as muscular dystrophy is being handled. We appreciate the entire team funding, late founding chairman, and our current chairman and vice chairman, along with the entire GROW lab, the gene therapy team, who we acknowledge for their tireless work, and all the funding support which supports ARCO in this mission. Thanks very much. Sorry, I exceeded the time.
One quick question,
Yes,
if anybody has.
Oh.
Yeah.
Thank you. Wonderful.
Thank you.
I'm Hemant Khanna, Astellas Pharma. I wanted to ask you about a couple of things. One was I'm assuming you did subretinal injections, correct?
That's correct, yes.
Could you give us some idea on when you did the ERGs on after you injected your...
3 months. 3
no,
months
but I mean, the amplitude, did it reach the wild type levels, or was it... Because I am assuming it's regular ERG, or is it...
No, it's animal.
Yeah, it's full field ERG,
yes,
correct?
Yes.
So did it reach wild type levels, or was it less than that?
I don't know that.
Okay.
Yeah.
And in this, could you also...
ARCO would have that data, yes.
That's okay. I think I was just remembering what RP65 had
I see.
in mice, and there were some issues because you did one subretinal injection, right?
Yes, one.
Yeah, so I don't know if that may reach the wild type levels. Just wanted to get your opinion on that.
Right.
The other one was, I like that idea of having those two split parts, but what do you recommend for genes which are even bigger that even that strategy may not work? Like you had written USH2A, EYS. I'm not sure about EYS, but I definitely know USH2A and Duchenne. Those may not be feasible even to split them.
Right. I'll tell you what ARCO has in mind. I don't have full authority on that. He does these concept called mini genes. He takes the most functional part and tries to do that rather than the entire protein.
I got it. Thank you.
Yeah, thanks.
Okay, you have a question? Yeah.
So do you mind if I ask a question? So in your data, you compared SEI and OAP in terms of functional rescue with full field ERG,
Yes.
and SEI was better than OAP. Just hoping to get your insights as to why you think that might be. Why would one approach be better than the other in terms of functional rescue?
So the splice enhancer introns helps in increasing the efficiency of stabilizing the mRNA as well. So he said it's intron-mediated enhancement. So there are more transgene there than the OAP. There are other data which supports that.
I see. Thank you.
Thanks.